Thank you very much. You'll be pleased to know that this is the last time you have to listen to me. So I'm talking about thyroid storm now. So same conflict of interest, and again what I'm presenting is what's also contained in the draft ETA guidelines on thyroid emergencies. Again, we'll have a case vignette. We'll talk about the definition, epidemiology and presentation of thyroid storm, scoring systems that are used, management, prognosis, and then a little bit about the guidance. So again, this will be a show of hands here. So this is a 53-year-old female patient who presented with acute confusion, abdominal pain, and shortness of breath. She was known to have Graves' disease, diagnosed 3 years ago, had stopped her medication because she was getting fat and had been lost to follow-up. She also has asthma and is on a steroid and salbutamol inhaler. So again, you can see that this patient is quite unwell, pulse 152 in atrial fibrillation, hypotensive, a respiratory rate of 24. She has a temperature of 38.5, saturations of 90% on air, and she's disorientated. She has muffled heart sounds and bibasal crepitations, and a tender abdomen with a palpable liver edge. You can see her white cell count is raised, she has a raised CRP, and her liver enzymes are disturbed. She has an ECG showing fast AF, and a cardiac echo shows that she has an ejection fraction of 30%. And you can see that she has thyroid function test here consistent with thyrotoxicosis and undetectable serum TSH, and raised free T3 and free T4. And so my question is, how do we manage this? Do we start high-dose PTU, high-dose carbimazole, amiodarone, remember she's in fast AF, diltiazem, or an emergency thyroidectomy? Anyone for 1? 2? 3? 4? Or 5? I think we're all agreed. Excellent. So again, I'll come back to this, but I think you've all got the answer right. So thyroid storm was defined in 1926 as a crisis of exophthalmic goiter. It's more commonly in patients with untreated or uncontrolled Graves' disease, and again is a life-threatening condition which is characterized by exaggerated signs and symptoms of thyrotoxicosis, but important here, you also need evidence of multi-organ decompensation. There's usually a precipitating event, and this may be thyroid or non-thyroid related, but in up to 40% there is no identifiable trigger. And the usual presentation, pretty similar to myxoedema coma, is an altered mental state, but in this case there is hyperpyrexia and cardiac dysfunction. So again, it's relatively uncommon, but an emergency, and therefore important that we talk about it. So there's an incidence of 0.2 to 0.76 per 100,000 per year. However, in hospitalized patients, the incidence is higher and up to 5 per 100,000. And in patients hospitalized with thyrotoxicosis, this is present in 16%. The mortality classically is reported as 8 to 25%, but recent series in the United States, and that's what that graph reflects, are the mortality rates per year in the United States, so from a combined registry, where you can see that this is up to about 3%. When you look at mortality figures from France, these are higher, and they report about 17%. And this is either because the French are rubbish at treating thyroid storm, or more likely because there is clinician variability in what they label as a thyroid storm. And therefore, I think some of the Americans may have labeled things thyroid storm that aren't thyroid storm. And again, out of interest, who has managed the thyroid storm in the audience? Okay. So what are the precipitants? Again, it's more common in women. Graves' disease is more common in women than in men, and the average age usually is around 50 years. So the most common underlying causes are, unsurprisingly, Graves' disease, an infection, and then treatment non-adherence. Certainly our patient had Graves' disease and treatment non-adherence. There are a number of other things that may elicit a thyroid storm in patients, such as amiodarone, patients undergoing surgery, either of the thyroid or non-thyroid related surgery. And again, this can occur in pregnancy or following trauma. And then there's a long list of rarer causes that is given there on the right-hand side. Again, signs and symptoms can be very varied. We have thyroid receptors in every organ, but again, it's usually a systemic decompensation, and then cardiovascular, gastrointestinal, and neurological signs that are present. So a fever is nearly universal. Patients often have signs of weight loss and diaphoresis. It's tachycardia and arrhythmias that worry us, associated with a drop in blood pressure, a variety of gastrointestinal symptoms, and then neurological signs. So again, here we have a scoring system. The most commonly known are the Birch-Rotowski criteria, where again you have a combination of effects, sort of systemic effects. So we look at the temperature of the patient, CNS effects, GI effects, cardiovascular, whether heart failure is present and whether there's a precipitating history. And again, coming back to a question that was asked earlier, thyroid function test results do not feature here. And actually, if you looked at the thyroid function test results of our patient, I have patients walk in my clinic with far worse thyrotoxicosis who are perfectly fine, and this patient was clearly not fine. So again, if this score is greater than 45, it's highly suggestive, but as has already been mentioned, lots of our patients on intensive care or in the acute admission unit will have a high score. Between 25 and 44, it's supportive, and less than 25 is unlikely. And again, I've indicated here the criteria that would apply to our patient that I illustrated, and she clearly scores well over 45. There are also the Japanese Thyroid Association criteria, and I had not heard or not read much about these before we started doing the guidelines. They actually have a good correlation with the Birch-Rotowski criteria, although they tend to underscore a little bit compared with the BWS criteria. And again, here you have two types, and it's a combination of having thyrotoxicosis. So they specify that you need to have abnormal thyroid function tests. They don't give any specific cutoffs. And then it's a combination of either one CNS manifestation together with other features such as fever, tachycardia, or heart failure, and you can see the other criteria here. But pretty similar criteria that are used looking at the multi-organ decompensation that is often common in these patients. Because it can present in such a widely varied way, and because it affects so many different organs, the differential diagnosis is really quite wide. And I'm sure, things like a pheochromocytoma, acute pulmonary edema, an aortic dissection, septic shock, psychosis, or acute psychiatric illness can be very difficult differential diagnosis to make in these patients who often have multiple comorbidities. And so what is the difference with a compensated thyrotoxicosis? So this is quite a nice paper here, published in 2014, which looked at hospitalized patients either who had compensated thyrotoxicosis versus those with a thyroid storm. So there were 25 that had severe thyrotoxicosis, which was compensated, and 25 with a thyroid storm. And you can see that was diagnosed using the Birch-Rotowski criteria, where those with a thyroid storm did fulfill the criteria. And then when you look at the various features, it's essentially the dark line here that are the thyroid storm ones. And so they just have a more severe phenotype of the various characteristics that the compensated thyrotoxicosis patients also have. And when you look at them individually in panel C here, this looks at fever, tachycardia, and you can see that this is definitely more pronounced in those with a thyroid storm. But then looking at the clinical outcomes, it is those patients who fulfill the criteria for thyroid storm that die, and not those patients with a compensated thyrotoxicosis. So what you can see here is what happened to inpatient mortality. Again, those patients with a thyroid storm, they are the ones who die. They are the ones who have the longest hospital stay and the longest admission to ITU. And when you look at the correlation between how high the Birch-Rotowski score is and their length of stay in hospital or length of stay in ITU, there is a clear correlation. So again, the scores do reflect how sick these patients are. So what do the ATA guidelines in 2016 tell us about hyperthyroidism? So this is one guideline that the ATA are not currently working on, as in a renewal of the hyperthyroidism one. But again, similar to myxedema coma, there is a need for aggressive treatment in patients who have a score that even approaches thyroid storm, and this requires senior clinical input, is what they say. And as always in medicine, prevention is better than cure, so avoid any abrupt discontinuation of anti-thyroid drugs and ensure that patients are euthyroid before elective surgery or labor, as we've already discussed in the case earlier, that it's important to normalize patients as much as possible to euthyroidism. And so this is a real picture provided to me by my friend who's writing the guidelines with me of someone who was assessed on the acute admission unit. I don't think this patient had a thyroid storm, but just to illustrate how people label things as a thyroid storm, and probably it isn't, because if they had a thyroid storm, they wouldn't be going home later today. So what are the principles of management? So there are various principles that you need to bear in mind. So you need to stop thyroid hormone secretion and synthesis, block the peripheral actions of thyroid hormones, reverse the systemic decompensation, treat the precipitating event, and then consider definitive therapy down the line. So I asked my son, who's very much more IT savvy than me, the bar is low, let me tell you, to make an AI picture of a thyroid storm. I think we're safe to say that AI is not going to take over the world looking at this picture. However, I did like the fact that this physician is mesmerized looking at the thyroid gland in the eye of the storm there, and probably that is the way we sort of stand there scratching our head when we deal with a real thyroid storm on intensive care. So I've already discussed the principles of management, but in this case it's really important that you use propyltyrosol and you need to give a big dose. Okay, so this is not 100 milligrams of PTU, this is 500 milligrams to a gram of PTU. And you then need to, as a loading dose, and then you give 250 milligrams every 4 to 6 hours. Often people use a combination of propyltyrosol and metimazole. So PTU has the added advantage that it blocks the conversion of T4 to T3. You need beta blockers, and both propranolol and esmolol are indicated, and often this, because these patients often have a cardiovascular collapse. So you need to discuss with a cardiologist on how to carefully instigate beta blockers, and that is to block the effects of thyroid hormones. So again, potassium iodide is very useful here. You can either use Lugol's iodine or potassium iodide tablets. And then again, here you give hydrocortisone, both because there may be underlying adrenal insufficiency, but also because this blocks the conversion of T4 to T3. And then again, supportive treatment is very helpful here. So often, and again in these situations, I've used cholestyramine because it inhibits the enterohepatic circulation of thyroid hormones. We've already talked about that in the case, but it binds to conjugation products of thyroid hormones. You need to treat the infection, you need to cool the patient, and you need the dehydration and CCF. Again, these patients need to be managed in a multidisciplinary setting on an intensive care, or at least high intensity care. Hypoanoic acid is a contrast agent used for cholecystography, and this inhibits D1 and D2. It is not really widely available. We can get it in Cambridge in the United Kingdom, and it's actually very good at blocking the thyroid gland if you don't have SSKI available. But again here, a multidisciplinary approach, and within 24 hours you need to inform your thyroid surgeon that you have a thyroid storm in the hospital, because if it doesn't get better with supportive treatment, then you may well have to resort to an emergency thyroidectomy. Again, involve the anaesthetist. They're usually on intensive care, but involve the anaesthetist. They may need respiratory support. And again, similar to myxedema coma, these patients tend to go hypoglycemic, so monitor their glucose levels and give nutritional support. Think of thiamine. Careful consideration of beta blockers, often in conjunction with a cardiologist. And usually, before you start giving iodine, first give the anti-thyroid drugs and then give the iodine to avoid worsening of thyrotoxicosis. Now, often these patients are very confused, unable to swallow. There is no intravenous anti-thyroid drug preparation available, so you have to insert an NG tube and give this via NG tube. And remember that the Wolff-Chaikoff effect from iodine may be transient, and in this area of the world sounds like it may be even more transient than in other parts. But usually, again, this is quite satisfying medicine in that patients improve with appropriate treatment within 24 to 72 hours. And if they don't improve within 24 to 72 hours, A, you need to question your diagnosis, and B, you need to consider, do I need to take the thyroid gland out? So this is our proposed guidance. Again, it's a little bit small, but it's essentially the same principles that I've already outlined. You confirm the diagnosis with checking blood test. You do all your screens, a septic screen, and it's important that you have a critical care input. If it's a woman, do a pregnancy test. This may present in pregnancy. And then you target systemic disturbance. You target the peripheral action of thyroid hormones, as we discussed. You block thyroid hormone synthesis, block thyroid hormone secretion, and then you also treat the underlying precipitating illness. So those are the principles of management, as we've discussed in previous slides. Just a few words about therapeutic plasma exchange. So this has been described, and I have used it in a number of patients. So this results in rapid clearance of thyroid hormones from the circulation. And the principle here is that thyroid hormones are bound to thyroxine-binding globulin, and this will be removed from the circulation. It's then replaced with colloid, usually albumin, and this provides unsaturated binding sites for circulating free thyroid hormones. It was first reported in 1970 as used in thyroid storm, and what this table here illustrates is what happens to circulating thyroid hormone levels 3T3 and 3T4 before and after therapeutic plasma exchange. So you can see that this actually works well, and it will bring thyroid hormone levels down. However, it's transient, and so you need to keep repeating this. But I've had a number of patients on intensive care where we have added in therapeutic plasma exchange. So it's an adjunct to all the medical treatments. It's not a replacement of those treatments, but an adjunct to those treatments that I've already described, and there is no consensus on use. So as I've already said, involve your surgeons early, usually within 24 hours of admission, and this is a multidisciplinary approach. And surgery may be indicated if patients don't improve when you expect them to improve with appropriate treatment. Those who have severe side effects to anti-thyroid drugs, and of course, many of these patients will have abnormal liver function tests, for example, because they have severe thyrotoxicosis. You know, our patient had abnormal liver thyroid function tests that then got significantly worse because she infarcted part of her liver. I've got her on high-dose PTU. You know, these are very nervous moments. And again, severe underlying cardiac or pulmonary comorbidities need to be assessed. And if the patient has this and is unable to manage the treatment, then surgical removal of the thyroid gland is useful. And this is treated with a total thyroidectomy. So I am lucky to work in a center where we have ECMO available. This is veno-arterial extracorporeal membrane oxygenation. So it's a temporary mechanical support for patients who have circulatory collapse. And this allows time for restoration of the euthyroid state and often results in complete recovery of the left ventricular function. And what is shown here in this table is a summary of the studies that have used ECMO in this situation. And you can see that the survival to discharge is really quite good. So again, small numbers. It's a rare condition, small number of cases where this has been needed, but a useful adjunct to the management. So longer term, wean off initial therapy slowly. Remember, T4 has a long half-life. If compliance is an issue, then early instigation of definitive treatment, and often make a plan before the patient is discharged from hospital, and control the thyrotoxicosis adequately before surgery. So in our patient, I was lucky to be able to have ECMO available, otherwise this patient would not have survived. She responded within a week to the medical treatment that was given. Like I said, she infarcted part of her liver and bowel and required surgery for that, and she had a total thyroidectomy 3 months following discharge. And she's fit and well now. So the most appropriate management, I think we all agreed here, was to start high-dose propylthiouracil. And to conclude, thyroid storm is a life-threatening emergency with significant morbidity and mortality. It's characterized by severe symptoms of thyrotoxicosis and multi-organ decompensation. There usually is a trigger. There are a number of scoring systems we can use to diagnose it, but again, there is no absolute lab value in thyroid function test that will help you make the diagnosis. The principles of treatments are to inhibit thyroid hormone synthesis, inhibit thyroid hormone release, block the effects of thyroid hormones, inhibit enterohepatic circulation, in addition to supportive measures and managing the underlying problem. And I cannot emphasize enough how important it is to have a multidisciplinary approach here. Thank you very much.